Harrison's medicine. Today's topic go for jaundice and evaluation of liver function. Jaundice, by definition, yellow skin pigmentation caused by elevation in serum bilirubin level, also termed icterus, often more easily seen in sclera. Scleral icterus becomes clinically evident at a serum bilirubin level of more than 51 micromole per liter or more than 3 milligram per deciliter. Yellow skin discoloration also occurs with elevated serum carotene levels but without pigmentation of sclera. Bilirubin metabolism is the bilirubin is the major breakdown product of hemoglobin released from erythrocytes. Initially, it is bound to albumin transported into the liver, conjugated to a water-soluble form glucuronide by glucuronyl transferase, excreted into the bile and converted to urobilinogen in the colon. Urobilinogen is mostly excreted in the stool. A small portion is reabsorbed and excreted by the kidney. Bilirubin can be filtered by the kidney only in its conjugated form, measured as the direct fraction. Thus, increased direct serum bilirubin level is associated with bilirubinuria. Increased bilirubin production and excretion, even without hyperbilirubinemia, as in hemolysis, produce elevated urinary urobilinogen levels. Etiology of hyperbilirubinemia occurs as a result of overproduction, impaired uptake, conjugation, or excretion of bilirubin. Regurgitation of unconjugated or conjugated bilirubin from damaged hepatocytes or bile ducts. Causes of isolated hyperbilirubinemia, indirect hyperbilirubinemia, hemolytic disorders, that is hereditary spherocytosis, elliptocytosis, G6PD, and pyruvate kinase deficiency, sickle cell anemia. Acquired disorder, acquired hemolytic disorders include microangiopathic hemolytic anemias, paroxysmal nocturnal hemoglobinuria, spur cell anemia, immune hemolysis, parasitic infections like malaria and babesiosis. Number 2, ineffective erythropoiesis. Cobalamin, folate, and severe iron deficiencies lead to indirect hyperbilirubinemia. Thalassemia also leads to indirect hyperbilirubinemia. C. That is increased bilirubin production. Massive blood transfusion leads to indirect hyperbilirubinemia. Resorption of hematoma leads to indirect hyperbilirubinemia. Certain drugs like rifampin, probenecid, ribavirin leads to indirect hyperbilirubinemia. Inherited conditions, Gilbert syndrome, that is isolated indirect hyperbilirubinemia, and Crigler-Najjar type 1 and type 2. Now the second entity is direct hyperbilirubinemia. Inherited conditions like Dubin-Johnson syndrome, Rotor syndrome, So, evaluation of jaundice. The initial steps in evaluating the patient with jaundice are to determine whether hyperbilirubinemia is conjugated or unconjugated. The second step is other biochemical liver tests are abnormal. Essential clinical examination includes history, especially duration of jaundice, pruritus, associated pain in the right hypochondrium, risk factors for parenterally transmitted diseases, medications, ethanol use, travel history, surgery, pregnancy, presence of any accompanying symptoms. Physical examination, hepatomegaly, tenderness over liver, palpable gallbladder, splenomegaly, gynecomastia, testicular atrophy, and the other stigmata of chronic liver disease. Blood liver tests and complete blood count. Algorithm for patient with jaundice. History, focus on medication and drug exposure. Then physical examination, laboratory tests, bilirubin with fractionation, ALT, AST, alkaline phosphatase, prothrombin time, and albumin. Isolated elevation of the bilirubin, indirect hyperbilirubinemia is more common, while direct hyperbilirubinemia is less than 15%. Drugs like rifampicin and probenecid, inherited disorder like Gilbert syndrome, Crigler-Najjar syndrome, hemolytic disorders, ineffective erythropoiesis. Direct hyperbilirubinemia is common in around 15% of patients. Inherited disorders like Dubin-Johnson syndrome and Rotor syndrome. Now, bilirubin and other liver tests elevated in certain conditions like hepatocellular pattern, that is ALT, AST elevated out of proportion to alkaline phosphatase. There is another pattern, cholestatic pattern. Alkaline phosphatase out of proportion is raised as compared to ALT and AST. Workup for the hepatocellular pattern includes viral serologies, hepatitis A, hepatitis B, hepatitis C screening, toxicology screening, acetaminophen level, serum ceruloplasmin level if patient is less than 40 years of age, and autoimmune screening, ANA, ASMA, and serum protein electrophoresis. If the results are negative, additional virological testing for cytomegalovirus DNA, Epstein-Barr virus capsid antigen, and hepatitis D antibody if indicated. Hepatitis E IgM if indicated. If the labs are negative, then we have to choose liver biopsy. The second pattern, that is cholestatic pattern, alkaline phosphatase raised out of proportion, ALT and AST. The investigation of choice is ultrasound. We have to look for dilated ducts, extrahepatic cholestasis, and CT, scan abdomen, MRCP, ERCP. If ducts are not dilated, intrahepatic cholestasis. For intrahepatic cholestasis, the serological testing includes anti-mitochondrial antibody, hepatitis serologies, hepatitis A, cytomegalovirus, Epstein-Barr virus, and review drugs. If the results are negative, MRCP and liver biopsy is the ultimate investigation. If AMA is positive, anti-mitochondrial antibodies is positive, then also we have to choose liver biopsy. Now, evaluation of abnormal liver tests, suspected liver disease, abnormal liver tests like acute is in less than 6 months and chronic more than 6 months. In acute, that is less than 6 months, ALT is raised, it shows hepatic and hepatitis, while if ALT and alkaline phosphatase both are raised. Diagnostic evaluation includes IgM for anti-hepatitis A virus, HBsAg surface antigen for hepatitis B virus, IgM for anti-hepatitis B core antibody, anti-HCV, ANA, ASMA, monospot heterophilic antibodies test, serum ceruloplasmin level, alcohol history, and drug history. Liver biopsy in acute liver disease reserved for patients in whom the diagnosis remains unclear despite medical evaluation. If there is cholestatic pattern of liver functions, that is alkaline phosphatase is raised out of proportion to ALT and gamma GT. Diagnostic evaluation, anti-mitochondrial antibody, drug history, ultrasound, MRCP, and ERCP. In chronic abnormal liver tests, that is more than 6 months, the workup includes hepatic pattern if there is more ALT raised, mixed if ALT and alkaline phosphatase both are raised. Again, we have to go for surface antigen evaluation, anti-HCV, iron saturation, serum ferritin level, serum ceruloplasmin level, alpha 1 antitrypsin deficiency, ANA, ASMA, ultrasound, and alcohol history. While in chronic cholestatic pattern of liver functions, the investigation of choice is drug history, anti-mitochondrial antibody screening, P-ANCA screening, ultrasound, abdomen, MRCP, and ERCP. Liver biopsy in chronic liver disease, often valuable for diagnosis as well as staging and grading liver disease. Now, the common entity is Gilbert syndrome, impaired conjugation of bilirubin due to reduced bilirubin UBP glucuronide transferase activity results in mild unconjugated hyperbilirubinemia, almost always less than 6 mg per deciliter of bilirubin, affects 3 to 7% of the population, more in males as compared to females. That is 7 to 1 ratio. Blood tests for liver functions used to detect presence of liver disease, discriminate among different types of liver disease, gauge the extent of known liver damage, and follow response to treatment. Bilirubin provides indication of hepatic uptake, metabolic conjugation, and excretory functions. Conjugated fraction, that is direct, distinguished from unconjugated by chemical assays. Hepatocellular conditions that may produce jaundice: viral hepatitis, hepatitis A, B, C, D, and E, Epstein-Barr virus, cytomegalovirus, herpes simplex virus, alcoholic hepatitis. Drug toxicity, which is predictable, dose dependent in acetaminophen toxicity, while unpredictable and idiosyncratic in isoniazid toxicity. Environmental toxin like vinyl chloride, alkaloids, kava, wild mushrooms, Amanita phalloides, Wilson's disease, and autoimmune hepatitis. There are certain conditions like cholestatic conditions that may produce jaundice, intrahepatic conditions, and extrahepatic, and certain benign conditions. So, cholestatic jaundice is seen in viral hepatitis. Fibrosing cholestatic hepatitis is seen in hepatitis B and hepatitis C, while cholestatic jaundice is also seen in hepatitis A, Epstein-Barr virus, cytomegalovirus infection. Alcoholic hepatitis is also cholestatic. Drug toxicity, that is pure cholestasis, is seen in anabolic steroids and contraceptive steroids. Cholestatic hepatitis seen in chlorpromazine and erythromycin. Chronic cholestasis is also seen in chlorpromazine and prochlorperazine. Primary biliary cirrhosis, primary sclerosing cholangitis, vanishing bile duct syndrome. There is chronic rejection of liver transplants, sarcoidosis, and drugs. They also lead to intrahepatic cholestatic jaundice. Congestive hepatomegaly and ischemic hepatitis has cholestatic tendency. Inherited condition like progressive familial intrahepatic cholestasis, benign recurrent cholestasis, cholestasis of pregnancy, total parenteral nutrition, non-hepatobiliary sepsis, benign post-operative cholestasis. Paraneoplastic syndrome presents as cholestatic condition. Veno-occlusive disease presents as cholestatic jaundice. Graft versus host disease, infiltrative diseases like TB, lymphoma, amyloidosis, infection like malaria and leptospirosis presents as cholestatic condition. Extrahepatic conditions that lead to cholestasis, number one, include malignancy, that is cholangiocarcinoma, CA head of pancreas, gallbladder cancer, ampullary cancer, malignant involvement of porta hepatis lymph nodes leads to extrahepatic cholestatic jaundice. Certain benign conditions that produce cholestatic jaundice includes choledocholithiasis, post-operative biliary stricture, primary sclerosing cholangitis, chronic pancreatitis, AIDS cholangiopathy, Meniere's syndrome, and parasitic disease like ascariasis also leads to cholestatic jaundice. Now let us discuss the aminotransferases, the transaminases, AST and SGOT, and alanine aminotransferase ALT or SGBT. Sensitive indicators of liver cell injury, greatest elevation seen in hepatocellular necrosis like in viral hepatitis, toxic or ischemic liver injury, acute hepatic vein obstruction, occasionally with sudden complete biliary obstruction from gallstone. Milder abnormalities in cholestatic, cirrhotic, and infiltrative disease. Poor correlation between degree of liver cell damage and level of aminotransferase. ALT, alanine aminotransferase, more specific measure of liver injury because AST also found in striated muscles and other organs. Ethanol-induced liver injury usually produces modest increases with more prominent elevation of AST than ALT. Next test is alkaline phosphatase, sensitive indicator of cholestasis, biliary obstruction, and liver infiltration. mild elevations in other forms of liver disease, limited specificity because of wide tissue distribution. Elevations also seen in normal childhood. Alkaline phosphatase is also raised in pregnancy as a normal phenomenon and bone diseases. The tissue-specific isoenzyme can be distinguished by fractionation or by differences in heat stability. Another enzyme is 5-nucleotidase, the 5-NT, pattern of elevation in hepatobiliary disease similar to alkaline phosphatase, has greater specificity for liver disorder used to determine whether liver is a source of elevation in serum alkaline phosphatase, especially in children, pregnant women, or patients with concomitant bone diseases. The gamma GT correlates with serum alkaline phosphatase activity. Elevation is less specific for cholestasis than alkaline phosphatase or 5-MT. Now, coagulation factors. Measure of clotting factor activity prolonged due to deficiency or inactivity. All clotting factors except factor 8 are synthesized in the liver, and deficiency can occur rapidly from widespread liver disease as in hepatitis, toxic injury, or cirrhosis. Single best acute measure of hepatic synthetic function, helpful in diagnosis and prognosis of acute liver disease. Clotting factors 2, 7, 9, 10. Function only in the presence of fat-soluble vitamin K. PT prolongation from fat malabsorption distinguished from hepatic disease by rapid and complete response to vitamin K replacement. The next test, which is albumin. Decreased serum levels result from decreased hepatic synthesis, chronic liver disease, or chronic malnutrition, or excessive losses in urine or stool. Insensitive indicator of acute hepatic dysfunction because serum half-life is 2 to 3 weeks of albumin. In patients with chronic liver disease, degree of hypoalbuminemia correlates with severity of liver dysfunction. Globulin. Mild polyclonal hyperglobulinemia often seen in chronic liver disease. Marked elevation frequently seen in autoimmune chronic active hepatitis. Next test is ammonia, serum ammonia level due to deficiency of hepatic detoxification pathways and portal systemic shunting, as in fulminant hepatitis, hepatotoxin exposure, and severe hypertension, portal hypertension. Elevation of blood ammonia does not correlate well with the hepatic function or the presence or degree of acute encephalopathy. Hepatobiliary imaging procedures. The first non-invasive examination of abdominal structure is by ultrasound, and 95% gallstones are picked with ultrasound, while much less sensitive for intraductal stones. Most sensitive means of detecting ascites is ultrasonography. While ultrasonography is moderately sensitive for detecting hepatic masses, but excellent for discriminating solid from cystic structures, useful in directing to percutaneous needle biopsies of suspicious lesions. Doppler ultrasound useful to determine patency and flow in portal and hepatic veins and portal systemic shunts. Imaging improved by presence of ascites but severely hindered by bowel gases. Endoscopic ultrasound less affected by bowel gases and is sensitive for determination of depth of tumor invasion through bowel wall. CT scan abdomen is the next investigation, particularly useful for detecting, differentiating, and directing percutaneous needle biopsy of abdominal masses, cysts, and lymphadenopathy. Imaging enhanced by intestinal or IV contrast dyes and unaffected by intestinal gas. Somewhat less sensitive than ultrasound for detecting stones in the gallbladder, but more sensitive for cholecystolithiasis, may be useful in distinguishing certain forms of diffuse hepatic disease, that is, fatty infiltration, iron overload, and copper overload. MRI, most sensitive detection of hepatic masses and cysts, allows easy differentiation of hemangiomas from other hepatic tumors. Most accurate non-invasive means of assessing hepatic and portal vein patency. Vascular invasion by tumor, useful for monitoring iron copper deposition in liver, that is in hemochromatosis and Wilson disease. MRCP, magnetic resonance cholangiopancreatography, can be useful for visualizing the head of the pancreas and the pancreatic and biliary duct. Next investigation is radionuclide scanning. Using various radio-labeled compounds, different scanning methods allow sensitive assessment of biliary excretion. HIDA scan by PIDA scan, PIPIDA, and DZDA scan, DISIDA scans. Parenchymal changes through technetium sulfur colloid liver, that is spleen scan, and selected inflammatory and neoplastic processes, we have to go for gallium scan. HIDA scan and related scans particularly useful for assessing biliary patency and excluding acute cholecystitis in situations where ultrasound is not diagnostic. CT, MRI, and colloid scans have similar sensitivity for detecting liver tumors and metastases. CT and combination of liver, colloidal liver and lung scans sensitive for detecting right subphrenic abscesses. Cholangiography is another investigation, most sensitive means of detecting biliary ductal calculi, biliary tumor, sclerosing cholangitis, choledochal cysts, fistula, and bile duct leaks may be performed by endoscopic, that is transampullary, or percutaneous transhepatic route allows sampling of bile and ductal epithelium for cytological analysis and culture, allows placement of biliary drainage catheter and stricture dilatation. Endoscopic route, that is endoscopic retrograde cholangiopancreatogram, ERCP, permits manometric evaluation of sphincter of Oddi and sphincterectomy and stone extraction. Angiography, most accurate means of determining portal pressures and assessing patency and direction of flow in portal and hepatic veins. Highly sensitive for detecting small vascular lesions and hepatic tumor, especially primary hepatocellular carcinoma. Gold standard for differentiating hemangiomas from solid tumor. Angiography is a gold standard for differentiating hemangiomas from solid tumors. Most accurate means of studying vascular anatomy in preparation for complicated hepatobiliary surgery, for example, portal systemic shunting, biliary reconstruction, and determining resectability of hepatobiliary and pancreatic tumors. Similar anatomic information, but not IV pressures, can often be obtained non-invasively by CT and MR based technique. Now, the final investigation, percutaneous liver biopsy, most accurate in disorders causing diffuse changes throughout the liver. Percutaneous liver biopsy should not be the initial procedure in the diagnosis of cholestasis. Contraindications to performing a percutaneous liver biopsy include significant ascites and prolonged INR. In such settings, the biopsy can be performed via the transjugular approach. Thank you very much.